I'm Dr. Pam Jarrett. I'm a geriatrician here in Horizon in St. John, New Brunswick. Currently, the research that we're involved with has to do with alternate level of care patients. So patients that are waiting in hospital for living arrangements in the community, the majority of whom are waiting for nursing home beds. We're also looking at the effectiveness of our memory clinic, which is an outpatient-based memory clinic for people with Alzheimer's disease and various forms of dementia, to see what works and what's effective and how we can improve things. My research has been focused on dementia and primarily how do we improve the care we provide to older people. The most recent and exciting research activity that we're going to begin, hopefully in the fall, will be with the Canadian Consortium of Neurodegeneration and Aging, which is a national research group which is funded through CIHR. And we'll be fortunate enough to be part of that with many of the other Canadian universities and hospitals and renowned researchers all across Canada in dementia. So we're very much looking forward to that. And the New Brunswick Health Research Foundation has been instrumental in helping us with that relationship and to help us secure the funding and has been able to give us some match funding for that. Research is important for many, many reasons. Ultimately it's to improve patient care and to improve the healthcare system. And how do we do things better? How do we be more efficient? How do we meet the needs of the population? Research in aging and research in dementia, with our aging population, there's tremendous opportunities. In the past, there hasn't been a lot of focus on research in aging. So this is a really wonderful time that we're starting to see a lot more research interest in this area, and the opportunities are huge. The funding of research is crucial. Research costs money, but the benefits of it are well worth the money that's spent. Because most of the time, research will give you answers to questions that we haven't had an answer to before, to know where should we invest money, what is effective treatment, what should we stop doing, what should we do less of, what should we do more of, and how do we improve patient outcomes. So continuing to fund research into clinical care and into aging, I think is going to be very, very beneficial for all New Brunswickers and Canadians.
My name is Ansar Hassan and I'm a cardiac surgeon here at the New Brunswick Heart Centre in St. John, New Brunswick. I have been on staff here since 2009, and one of the mandates that I was given when I first arrived here by Dr. Mark Pelche was to develop the cardiovascular outcomes research program. Over the past 6 to 7 years, we have really developed a program that is robust in terms of its ability to not only ask research questions of relevance to our patients, but to actually answer these questions. In that time period, we have formulated the cardiovascular research program in New Brunswick, or COVER-NB. And initially, when we started the program, we were limited as far as the number of resources that were available to us. But having said that, with the existing cardiac surgical database that was already in existence here at the Heart Center, and the hiring of a statistical analyst to work with me, we quickly grew the program. And over the course of the past 5 to 6 years, we've really seen an emergence of a first-rate cardiovascular outcomes research program here in St. John. We pride ourselves on having been able to establish multiple studies that have been recognized both locally as well as nationally, that have been published in peer-reviewed journals. And the focus of our research really has all along been the delivery of cardiovascular care in New Brunswick, and more specifically the delivery of tertiary cardiovascular care in New Brunswick. And a lot of the studies that we've done have looked at how is it that we're delivering this care, whether or not we can do better, so that at the end of the day, the result of our research is more than just academic productivity. It's about improved patient care. And that's how it, for me, ties my two focuses together, or my two loves, which is, being able to be a cardiovascular practitioner as well as being a cardiovascular academic researcher. None of what we have accomplished to this point would have been possible without research funding. Over the past few years, we've managed to get funds from a variety of different sources, and that's been of great importance to us because it has allowed us to hire a variety of different research personnel to help us and to allow us to grow this program. The various personnel don't only provide us with greater capacity, but they also provide us with greater expertise to allow us to perform different research projects, to tackle projects that we never would have been able to tackle before with the limited resources that we had when we first started. And the type of research that we do really is so that we can better understand how it is that we're delivering care so that we can improve patient outcomes at the end of the day.
Our center here at the Stan Cassidy Center is a very interdisciplinary group that over the past 10 years we've really grown our research capacity to have this core interdisciplinary team. So we have physiotherapists, occupational therapists, psychologists, rehabilitation physicians all working together very specifically around areas of improving mobility and improving function for people who live with disabilities. One very interesting project that we've been working on over the past couple of years is looking at using electrical stimulation techniques in a functional way. So you activate muscles that are paralyzed, and by activating them with this electrical current, you then, for instance, can make a hand open and close so that you can hold something, or you can activate muscles in a leg and perhaps pedal a bicycle. And we're looking to try and see if by doing these types of therapies, if we can actually improve a person's neurologic recovery, actually make a difference at the brain and spinal cord level that will impact on their long-term recovery. We're also looking at the various health impacts of doing electrical stimulation types of therapies. So looking at patients' spasticity or management of their tone, looking at their quality of life, and looking at their pain outcomes. It's always a challenge when you're working with people who have particular diseases that aren't very common, perhaps a little more rare, or not as affecting such a great number of the population. And that's the case for many of our patients. Individuals who've had spinal cord injury or who are impacted by diagnoses like multiple sclerosis or Lou Gehrig's disease. And so we really have to work hard to advocate for health dollars directed towards research towards these smaller groups of populations. And even though these patients represent a smaller, perhaps, percentage than what we might see in diabetes or heart disease, the implications of living with an impairing disease, how it impacts on your mobility, significantly impacts the cost to the system, the psycho-emotional and socioeconomic costs for an individual and their families, and that impact on the community. So even though sometimes when we talk about doing research in spinal cord patient, we say, well, you only have maybe 30 to 50 patients a year with a spinal cord injury. But the lifetime costs for a patient like that can approach the millions. And therefore, investing upfront healthcare dollars towards clinical health research for these populations gives us the potential to really make a significant long-term impact, not just for the patient, but for the community as a whole, and our overall healthcare and economic burdens.
Je m'appelle Gabriel Giroir, je suis microbiologiste infectiologue à l'hôpital Centre hospitalier universitaire Dr Georges Dumont. Mon travail est à la fois clinicien et aussi microbiologiste, donc il y a une partie laboratoire. L'hépatite C, il y a quelques années, était considérée une maladie difficilement traitable avec des médicaments qui fonctionnaient entre 50 et 75 du temps, avec des médicaments qui étaient associés à beaucoup d'effets secondaires. La situation de l'hépatite C a tellement changé. Maintenant, on a accès à des médicaments curatifs uniquement par la bouche, plus d'injections. Avec pratiquement aucun effet secondaire, mais c'est sûr que le contexte financier est toujours très complexe. Et ça, de corréler la clinique avec le laboratoire, ici étant le laboratoire de référence diagnostic en virologie du Nouveau-Brunswick, on a été le premier laboratoire à répertorier au Canada l'adénovirus sérotype 14. Depuis quelques mois, c'est des biomarqueurs pour l'infection bactérienne, donc ce qu'on appelle la procalcitonine. C'est un test sanguin rapide qui nous permet très rapidement d'identifier un patient qui souffre d'une infection bactérienne sérieuse.
Alors bonjour, je m'appelle Richard Garceau, je suis médecin microbiologiste au Centre hospitalier universitaire Dr Georges Dumont. J'y travaille comme médecin spécialiste en microbiologie médicale puis consultant en maladies infectieuses depuis 1991. Puis je suis aussi la personne qui a beaucoup travaillé pour créer le laboratoire provincial de diagnostic des maladies virales à l'hôpital Dumont. Alors, mon rôle, en général, c'est de m'occuper du laboratoire de microbiologie avec mes confrères et mes consoeurs. C'est aussi de superviser le travail qui se fait, puis l'avancement qui a eu lieu pour le diagnostic des maladies virales. Alors, initialement, quand on a commencé le laboratoire, le diagnostic des maladies virales se faisait par de la sérologie, la détermination d'anticorps par des échantillons sanguins. Puis, par la suite, quand je suis arrivé, on a commencé à faire pousser les virus, la culture virale. Puis, vers 1996, on a commencé à faire le diagnostic moléculaire des maladies infectieuses, en commençant par la chlamydia et la gonorrhée, le dépistage de ces maladies-là, au lieu d'utiliser d'autres types de technologies. Mais il va nous arriver, soit dans des spécimens de laboratoire qui sont soumis de routine, soit dans d'autres situations, tomber sur des situations exceptionnelles où, pour l'avancement de la science puis pour le bien-être de la communauté médicale, on va faire des rapports de cas, on va décrire des situations épidémiologiques où on va parler du fonctionnement de certains tests, dont des tests commerciaux qu'on utilise à l'hôpital pour faire le diagnostic des maladies.
So my name is Duncan Webster, and I'm an infectious diseases physician and medical microbiologist at the St. John Regional Hospital. I'm from St. John originally, and when I came back home to work, I was really struck by the amount of infectious disease I was seeing on an inpatient and outpatient basis related to addiction. So what we found is that if you look at marginalized populations locally within St. John, within New Brunswick, you could easily argue that the most relevant infectious disease or communicable disease is hepatitis C. So if we take our opiate-addicted population locally, about 50% of people are hepatitis C positive. And what we're seeing now is we've got the opportunity to do a screening, which can help us with prevention strategies. And with the new direct-acting antivirals, there's an opportunity to treat very effectively and new curative therapies. So with that, it's really important we gather information to help us to provide optimal care and to use taxpayer dollars wisely. Another area of interest that I have is zoonosis or zoonotic infectious diseases, which would be infections acquired through exposure to animals. And what we're seeing within New Brunswick is as we have warmer climate we're starting to see some infections that were traditionally more common south of us through New England and further south along the eastern seaboard now become more prominent locally in New Brunswick. So we have the opportunity to do seroprevalence studies to get some baseline data. What is going on in New Brunswick? We actually don't have a great idea because we haven't done the research to this point to see on a population basis what is the seroprevalence. And so through funding, we've been able to work towards acquiring sera on a population basis and identify seroprevalence rates for some of these tick-borne and mosquito-borne illnesses within New Brunswick. So my experiences with regards to obtaining funding have been quite positive, but with regards to our hepatitis C work, we're working with marginalized populations, and so it's not just a one-off research project, but it really does involve ongoing clinical care, prevention and treatment and ongoing follow-up. And so for that reason, to have sustainability is critical. And that's been a challenge because we can get dollars that work for a time, but if those dollars run up and we can't sustain, then there are major issues with regards to clinical care and ongoing follow-up. So it has been a challenge.
Mon nom est Ali Benjenou, je suis un oncologue médical. L'implication dans des équipes d'oncologie dans la recherche est quelque chose de primordial. Personnellement, je suis plus impliqué dans la recherche purement clinique. Que moi, je fais, c'est essentiellement basé sur les cancers de la prostate, les cancers génito-urinaires, puis dans le cancer du sein.
Je m'appelle Nicolas Finn. De mon côté, ce que je fais plus, c'est de la recherche en hématologie et en oncologie médicale. Les sites principaux d'intérêt sont les maladies comme le lymphome ou la leucémie, puis aussi les tumeurs neuroendocrines dans lesquelles on a été quand même impliqués un peu plus dans les dernières années. Les études cliniques sont très importantes pour les patients. Ça nous permet d'avoir accès à des nouveaux médicaments qui sont prometteurs pour traiter le cancer.
Mon nom est Skander Guidira, je suis un oncologue médical ici et je suis le chef de service de l'oncologie médicale à l'hôpital Georges L. Dumont. Notre objectif maintenant, c'est d'essayer de développer la recherche à distance. On gère plusieurs centres satellites, ce qui va être une première au Nouveau-Brunswick. La recherche qu'on fait actuellement, c'est fait par site parce qu'on est plusieurs médecins et chaque médecin traite un site particulier. Personnellement, je traite beaucoup le cancer de la femme d'une façon générale, qui englobe les cancers gynécologiques et le cancer du sein.
C'est ça, je suis docteur Saint-Hilaire, je suis hémato-oncologue, donc à l'hématologie. Les recherches qu'on fait ici, c'est surtout des recherches cliniques, c'est-à-dire où on va proposer des nouveaux traitements comparés à un ancien traitement, puis ça donne l'opportunité aux patients d'avoir accès à de nouveaux médicaments. Mais on a aussi un projet où on fait plus de la recherche. Donc, c'est surtout du point de vue colorectal, les mélanomes et les cancers hématologiques dans lesquels moi je suis impliquée. Souvent, ça vient avec un financement donc d'une compagnie pharmaceutique ou du NCIC, qui est un organisme canadien.
Donc, je suis Pierre Whitlock, je suis hématologue, oncologue médical à Moncton, centre oncologie Dr Léon Guichard depuis 1998. On a fait de multiples essais cliniques pour des nouveaux médicaments dans le cancer, principalement au début, cancer du sein. Maintenant, on a pas mal d'études dans tous les différents types de cancers qu'on peut retrouver. La recherche clinique, c'est quelque chose qui est essentiel en oncologie. Donc, on participe de plus en plus à des nouveaux protocoles dans d'autres types tumoraux. À l'époque, on avait peu de médicaments pour le mélanome, le cancer du rein, ça c'est la prostate. Maintenant, c'est 3 cancers où il y a une explosion de traitements. Et évidemment, il y a beaucoup de protocoles qui nous sont proposés et on essaie d'y participer le plus facilement possible. C'est un peu ce que j'avais à dire. Encore une fois, je me résume, mais la recherche clinique, c'est indissociable d'une pratique moderne de l'oncologie médicale. Ça fait partie intégrante.
I'm Dr. Paul Atkinson. I'm the Program Director for the Research Program in Emergency Medicine, which is a combined program between Dalhousie University and Horizon Health Network here in New Brunswick. It's a relatively new program, but I think over the past 5 years we've been very successful. We have managed to get over 30 research projects up and going. We've had multiple publications, lots of presentations, and have managed to win some national awards as well as some regional awards. We focus in our program of research on 4 main topic areas: trauma and resuscitation, patient care delivery, point of care ultrasound, that's taking ultrasound to the patient at the bedside, and then knowledge to practice, which really is a simulation program. We use simulated patients and use models and mannequins to allow training for residents, students, to help them practice better when they actually see real patients.
I'm Mike Howlett. I'm the department head for emergency medicine here at the St. John Regional Hospital, and I'm also an associate professor at Dalhousie University. One of the reasons to establish a research program in healthcare is because research programs are not really separate from clinical work. Clinical work depends very heavily on being able to deliver the care that's the best and the most current, and that's been researched well, that there's good evidence for it, and that people are reliably trusting what we give to them when they come here. In fact, in St. John and in many other places, we see upwards of 3/4 of the whole population in terms of the patient volume per year in our emergency and urgent care departments. So it really matters to the population that we can deliver good care that is on the forefront of the education and research that's out there, and as such we need to be involved in research and research programs and education.
All of this great research that we're doing though is dependent upon time, people's time, the support, having coordinators, having students, having nurses, having physicians get involved, because this is all done on top of people's regular clinical work. And as a rule, most people in the healthcare system are relatively busy. And then to ask them to participate in research, it's an extra step, it's more of their time. And so that's why it's important to be able to fund research appropriately, so that it isn't an amateur activity, but it's done in a professional way, with support, with funding, with statisticians, methodologists, research coordinators, and physicians and students who have appropriate training in research methods and can therefore do it appropriately and optimally in this setting. We're very grateful for the funding we've received locally and provincially for our program, but we need to continue to increase the funding so that we can continue to grow our program.
My name is Neil Manson. I'm an orthopedic spine surgeon in St. John, providing spine care for the province of New Brunswick. I came to St. John in 2006, and I was very fortunate to work with Dr. Ed Abraham. And with that relationship, we've been very lucky to not only provide, I think, solid clinical care to our New Brunswick patients, but also push forward the research that we're doing. Dr. Abraham and I might start to pick up on a specific problem related to a certain type of surgery. So for example, for one of the complex procedures we do in our older patients for very severe arthritis and scoliosis, we do a very major operation, which at one point we were noticing there was a number of significant problems after surgery with that. And we were able to do the research and look at the data and see, in fact, yes, there were important problems in a small subsection of the total amount of patients we were operating on, and we were able to really focus on those patients, address those problems, and work to prevent those problems in the next group of patients coming down the pipe. And really that's where research is most beneficial. When we can attack a problem that we see clinically, address it, and make it so the next patients coming down the pipe don't have that problem and ultimately have a better result from their treatment. And that's, if research is changing your clinical practice in a positive way, then then we're winning. That's what we're doing the research for. And you know, I think if clinicians are not tracking their outcomes in some formal process, then unfortunately the opportunity to miss those chances to improve the success of patient care is sometimes can occur. Research in 2015 would not be possible without research funding and support. The expectations for the quality and the detail of not missing any data points, the requirements by our ethics committee and by publication committees to really have the data exact, have it accurate in its composition and the way we put it together, has become appropriately demanding that for a clinician to do that on his or her own is very challenging. So that brings in the need to have our support team work with us, and that has a cost attached to it. So from a research standpoint, it's imperative to have that provincial, private, and industry support to get the work done.
My name's Gordon Dow. I'm an infectious disease consultant at the Moncton Hospital. I've been working here since 1995. It's been a real privilege for me to work here because this hospital had the first infectious disease program in New Brunswick. As part of this program, one of the things that has developed here is a research program. And this research initially was directed at HIV care. So we began attracting studies looking at new antiretroviral drugs for the treatment of HIV. And we have seen HIV during this period of time go from an untreatable disease to now we have a very treatable disease thanks to a lot of that research. So this was life-saving research. It brought drugs to New Brunswickers that they otherwise wouldn't have had access to.
My name is Dr. Dan Smythe, and I'm an infectious disease physician at the Moncton Hospital and director of research for the RECAP program. Much of our research efforts over the last 2 years have been centered around the clinical care of patients with chronic hepatitis C infection. In the spring of 2014, we debuted our hepatitis C infected and at-risk database, our HERE database, which is a treatment registry tool for all patients seen in the clinics within Horizon. The registry has seen over 350 patients enrolled in the last 12 months alone. It's a very agile evaluation tool that allows us to ensure that we're providing good therapy to patients, to ensure that the money we spend on these drugs is well spent, and has formed a research platform for many collaborations within our own province, within Atlantic Canada, and nationally.
When you look at research funding in New Brunswick, I would say that we definitely need to bring more money in. The money that comes into Canada for research, much of it gets distributed to central Canada and the West, and I would say Atlantic Canada is not receiving its due share of research. And I think that this is a fabulous environment for encouraging more research, and we're very, very pleased with the support we're getting to help foster more research and investment in Eastern Canada.
I'm Margot Brunel. I'm a medical oncologist at the St. John Regional Hospital and clinical department head. I've been practicing in St. John since 1986 and have been involved in clinical trials since I first joined. My area of interest in clinical research is centered around cancer cooperative trials, primarily with NCIC and RTOG, now NRG. It has been involved in entering patients into trials to look at improvement of efficacy, toxicity, quality of life, and cost effectiveness of the treatments that we offer our patients. I've had the privilege of leading a large adjuvant breast cancer study, NCIC MA21, co-chaired with Mark Levine from Hamilton. This was a study looking at 3 different types of chemotherapy regimens, exploring the question of dose intensity and dose density of chemotherapy. It was essentially a negative trial, but provided important information, allowing investigators, including myself, to answer ancillary questions of wait times to chemotherapy, risk of febrile neutropenia, weight influence on chemotherapy outcomes. Currently, my interest is in the survivorship realm, and in conjunction with Dr. Sadan Narayana, a psychiatrist at the St. John Regional Hospital, we were successful in obtaining the MindCare Transformational Grant. We are hoping to look at partners of breast cancer patients and study their distress scores and see how that affects their long-term marital relationships. So it's transformed from active treatment throughout the whole patient journey into survivorship. We have participated not only in academic trials through cooperative groups such as NCIC and RTOG, but also in the pharmaceutical trials. Both ask very important questions and often very different questions that can't be asked by the other groups. Funding through NCIC has been on a per patient basis and has covered very basic costs. By being very efficient in our clinical trials office, we have been able to maintain financial stability and sustainability. We do try to do some industry-sponsored trials, as they traditionally have paid more per patient recruitment, but we still endeavor to make science and the question being asked the most important determinant to what trials we participate in. So it is important to participate in a whole spectrum of trials, and that has been very sustainable. We've had good support from our institution and from the allied health departments in helping to fulfill our mission, and are pleased to offer that to our patients as part of standard oncology care.
I'm Angie McGibbon. I'm an endocrinologist here in Fredericton, New Brunswick, and I work in the clinical realm mostly. I also have an administrative role within medical education in the province and in the local area. I started doing some research projects more for my own entertainment or interests over the past 5 years, and originally started working in some areas of diabetes. In New Brunswick, we have about 56,000 people who have diabetes. We've done a lot of work in our province to address what was thought of about 10 years ago as a lack of diabetes initiative. There is a report card done by the Canadian Diabetes Association several years in a row that identified New Brunswick as having a D level in terms of diabetes care. All of us who work in the area in diabetes in New Brunswick knew that we weren't taking care of our patients at a level of D, that we were all taking care of our patients well. But the problem is that we didn't have an organized structure within the province to understand what we were doing. And so over the past 10 years, there's been this amazing growth of diabetes structure and data that have been developed through the government of New Brunswick, actually, through the primary care group. And so that has allowed us to really understand how we're taking care of it. We now have a repository of all the people with diabetes, And that information is really the basis for what could be an amazing research focus or project to understand diabetes in a rural place like New Brunswick. I think I've been very lucky at getting funding so far. Diabetes Innovation Grants through the government have been very, very helpful for startup grants. And so I haven't had as much trouble as some people in getting the funding for these. I think what's going to be the challenge is taking these small projects and making them into a real research focus. Because that's going to take much more funding, it's going to take a lot more people, it's going to take more time. And for me, all of the work that we do in research is in the evenings and weekends. It's not part of my job. I do it because I enjoy it and I have good colleagues. But I think the challenge will be finding time and growing these small projects into something bigger. And I don't know for sure how that's going to work, but it's really nice that we have things like Diabetes Innovation Grants or the New Brunswick Health Research Foundation. Our own research services have been very supportive to help us try to figure out where to go with some of these projects. So I feel pretty lucky in that regard.
I'm Martin McKinnon. I'm a nephrologist here at Horizon Health. I'm primarily a clinician. I do a lot of work with patients with kidney disease, particularly end-stage renal disease and patients on dialysis. But I also, on the side, I suppose, pursue some research interests as well. I think research should always stem, from a clinician point of view like myself, from questions that we ask in everyday medicine. And those questions that either I ask or that the residents or students that I work with ask, often we pursue in research projects here in nephrology. So, for instance, we've been involved in medical education type research projects where we've looked at the use of iPods and medical applications on the clinical teaching service in the internal medicine unit. A student I'm working with right now is going to be looking at the effectiveness of the morning report before the start of the clinical day and its impact on what happens to patients during their hospitalization. So that's sort of on the medical education side. I'm also involved in some investigator-initiated studies in dialysis itself, both at looking at medication adherence, as well as looking at the importance and the effects of different medications on mineral metabolism, for instance, in these complex patients. And finally, we're fairly heavily involved in the nephrology program with industry-sponsored research, looking at new medications for the treatment of a variety of conditions in kidney disease. We've been growing from an industry-sponsored point of view for sure, and we've brought funding into the department, which has allowed us to hire research nurses and propagate both investigator-initiated studies as well as continue on with our industry-sponsored studies, and that's been fairly fruitful. Our next plans and I guess next initiatives will be to expand our granting requests along the lines of research projects that we want to do and go after sort of funding that's been increasingly available, I think, in New Brunswick over the last several years.